Hi, this is Michael Altos, and we are recording a series on anesthesia and the endocrine system, which comes from Barish Chapter 46. This is going to cover 2 weeks worth of lecture sessions, and this is part 1 of the recorded lecture series. The first part of the endocrine system we're going to discuss is the thyroid gland. Just for a very brief reminder, the axis of the thyroid system begins in the hypothalamus, where thyroid-releasing hormone is secreted. That acts in the anterior pituitary gland, and we'll discuss the pituitary in more detail later on. It causes the pituitary gland to secrete TSH, thyroid-stimulating hormone, and that goes to the thyroid gland and stimulates the release of thyroid hormone, specifically T3 and T4. Also, just a reminder that these hormones circulate in the body bound to a protein called thyroid binding globulin. And then, of course, there are negative feedback loops throughout this system as well. What kind of lab studies do we get on patients to assess their thyroid function? Well, the most common is the TSH, the thyroid stimulating hormone, which is your first screening test for thyroid dysfunction. This is based on the negative feedback loop that I just described, where iodine and thyroid hormone, when they are present in high levels, will in turn inhibit the secretion of TRH and TSH. So patients who are hyperthyroid may in turn have a low TRH and TSH, whereas patients who are hypothyroid may have a high TSH. And of course that depends on where in the axis the problem exists. And for that reason, other studies may be necessary, like T4 and T3 levels. You can look at total or bound or free levels. Because of the protein binding, these aren't as reliable, and they're usually used as secondary studies to help clarify the diagnosis and the location of the pathology. A few reminders about thyroid hormone. About 80% of T3 is produced by extrathyroidal deiodination of T4. So this is what they call peripheral conversion of T4 into T3. And T3 is much more potent, maybe about 4 times as potent as T4. And very, very little of thyroid hormone is actually free circulating hormone. It's almost all bound to the thyroid binding globulin. You can also measure thyroid binding to the thyroid binding globulin, and these are various tests that you learned about in medical school, like T4 uptake and free T4 index and things like that. Studies that we won't really be focusing on today. The signs and symptoms of hyperthyroid are pretty classic. They are all signs of a ramped up metabolic system. So we see patients who have weight loss and tremor. They may have GI upset like diarrhea. They may complain of weakness or warmth or heat intolerance. They can have anxiety, tachycardia, a widened pulse pressure, and in extreme cases they can go into atrial fibrillation or heart failure. Here we have a picture of proptosis, which is more specific not just for hyperthyroidism, but usually the hyperthyroidism of Graves' disease. There are many different causes for hyperthyroidism. Some of them are intrinsic to the gland itself, like a toxic multinodular goiter or a thyroid adenoma. People can also be hyperthyroid due to Graves' disease or thyroiditis, or may even have extrathyroid causes. So iatrogenic hyperthyroidism due to overdose of synthroid, increased iodine uptake, TSH secreting tumors, or other carcinomas. The primary medical management of hyperthyroidism involves anti-thyroid medications like PTU, which is propylthiouracil or methimazole. Patients may also take iodide salts like sodium or potassium iodide. And as far as anesthesia is concerned, we do expect patients to be euthyroid. And from diagnosis of true hyperthyroidism until euthyroid state may take 6 to 8 weeks to medically manage and optimize these patients. And except for emergency surgeries, these patients should be postponed until their thyroid levels are under control. In the perioperative period, we want to avoid giving our patients any sympathetic medications. And these are the kinds of medications that show up on board exams a lot whenever you're trying to avoid sympathetic stimulus. So those would be ketamine, pancuronium, and ephedrine, all of which increase heart rate and blood pressure. and halothane, which is arrhythmogenic and may not be the best choice in patients who have increased exposure to epinephrine. Other anesthetic considerations include the possibility of a co-incident myasthenia gravis in patients who have, I think, Graves' disease, in which case we would want to reduce our initial dose of neuromuscular blocking agents. Patients who have a goiter may have a difficult airway and may be at increased risk for airway obstruction, and remember that goiters can extend below the sternum and cause mediastinal mass-like pathology. Post-operative, after any neck surgery, including thyroid surgery, we have to be aware of the possibility of nerve damage, specifically the superior laryngeal nerve and the recurrent laryngeal nerve, leading to possible dysfunction of the vocal cords and stridor or obstruction. Patients can, of course, have hematoma, which can rapidly expand and obstruct the airway. Also, during total thyroidectomy, there is some risk of becoming hypoparathyroid, which leads to hypocalcemia. And we're going to discuss this more shortly when we discuss the parathyroid gland. Finally, as I showed in the previous picture, Graves' disease can lead to exophthalmos, the protrusion of the eyeballs, which leads them to increased risk of corneal injury. And does being hyperthyroid increase your MAC? This is debated. There are some who say yes, and that patients who are hyperthyroid may need additional anesthetic compared to the average population. The extreme of hyperthyroidism is thyroid storm, or thyrotoxicosis. I always remember this with the mnemonic, thyroid storm is deadly, which reminds me of the 4 things that are most commonly found to precipitate thyroid storm: trauma, surgery, infection, and diabetic ketoacidosis. Thyroid storm is really just the hyperthyroidism we described in the previous slide, plus mental status changes, and it's to the extreme. So this can look actually like malignant hyperthermia or pheochromocytoma, with great swings in blood pressure and heart rate. And thyroid storm is deadly. It can really lead to rapid decompensation and death if it's not diagnosed and treated rapidly. The primary management of thyroid storm is beta blockade. A lot of people get confused and think you should start some anti-thyroid medications, and that's certainly important, but the primary thing we need to do is get this tachycardia especially under control. And so beta blockade, classically with propranolol, is the primary treatment of choice. Some people have used esmolol, and that's also considered an acceptable first management for thyroid storm. This treats the tachycardia. It does help with anxiety and tremor as well. We should bear in mind that any thyroid that's already out of the barn, so to speak, any thyroid hormone that's already been secreted, won't be stopped by the beta blockade. And for that matter, thyroid hormone that's in the gland could still storm out of the gland, and beta blockade isn't necessarily going to help with that. One aside is that propranolol does inhibit the peripheral conversion of T4 to T3. And so in that sense, the beta blockade may help with some of the thyroid hormone that's already been secreted. Nevertheless, this is our first step in treatment. The advantage of esmolol over propranolol is it's shorter acting and more titratable, and it may be a better choice in patients who have heart failure. Another drug to get on board early would be steroids, most commonly dexamethasone or hydrocortisone. These do seem to reduce secretion of thyroid hormone, and they also inhibit peripheral conversion of T4 into T3. Now, the anti-thyroid hormones should be administered as well in order to prevent any further synthesis and secretion of thyroid hormone. And those would be, again, PTU or methimazole. Remember that these drugs are really only available by oral formulation. So if they can't be given to the patient orally because they're too obtunded, they may need to be crushed and administered through an NG tube. Can they be crushed and dissolved and put through a filter and given IV? I believe that's been described in the literature, but I guess your pharmacy would have to be on board with that plan in order to implement that. Later on, iodide salts like sodium and potassium iodide may be indicated, and ideally you would try to do that in discussion with an endocrinologist in order that you don't mess up any of their future thyroid studies. Finally, other supportive care like IV fluids, rapid cooling with ice, with cold fluids, are all appropriate. Acetaminophen to lower temperature is important. And classically, we teach that you should not give aspirin to these patients because it will displace the protein-bound thyroid hormone and actually worsen their thyroid storm. We'll pause here in case you have any questions that you can email me or bring them to class and we can discuss them in more detail. Now on the other end of the spectrum, we can discuss hypothyroidism. And the signs and symptoms are pretty much the opposite of hyperthyroidism. So we see patients who have depressed mood, become lethargic, and have cold intolerance. They may have bradycardia and a decreased response to hypoxia and hypercapnia. And hypothyroidism also has several causes. It can be primary due to disease of the thyroid gland that is autoimmune, iatrogenic due to thyroid ablation or thyroidectomy. Patients can develop thyroiditis, which can cause hypothyroidism, and an iodine deficiency can also lead to decreased thyroid hormone production. Patients can also have pathology of the pituitary or hypothalamus, and that can lead to hypothyroidism as well. Now, do patients need to be euthyroid to have surgery? Well, certainly we said they shouldn't be hyperthyroid, but what about hypothyroid? Well, the data pretty much shows that unless it's really, really severe hypothyroidism, it's probably not necessary to correct the hypothyroidism before surgery. Hypothyroidism is much less of a problem in the anesthetic state. There really aren't any agents that are absolutely contraindicated in these patients. There are some studies that suggest that these patients have a decreased level of pseudocholinesterase, which would suggest care in dosing succinylcholine. And the only caution that we've seen is that patients who have symptomatic hypothyroidism and coronary artery disease may benefit from CABG prior to elective surgery. You may want to consider an A-line in patients who have this situation, very severe symptomatic hypothyroidism, if you're forced into doing an anesthetic, say, under emergency conditions. And is there any effect of decreased thyroid function on MAC? Studies say there is no effect. So being hypothyroid does not reduce MAC. Just like hyperthyroidism can lead to thyroid storm, so hypothyroidism can lead to something called myxedema coma. This is a condition where patients develop stupor, hypotension, they start to hypoventilate, and can even become hyponatremic. This can also be a very severe and even fatal condition. If patients present in myxedema coma and require surgery, this should only be done if it's a life-saving emergency intervention. Otherwise, the patients should be stabilized because the mortality rate is up to 50% in these patients. The primary management of myxedema coma is to provide thyroid replacement, and thyroid hormone is available in IV formulation. So that should be given, along with steroids and warming, because these patients usually present with decreased body temperature. The patients are at some risk for myocardial ischemia, so that should be closely monitored. Again, if you have any questions, please make note of them, and then we'll move on to the next section here. We're also going to discuss the parathyroid gland. The parathyroid gland, or actually glands, because there are 4 of them, are really responsible for calcium homeostasis in the body. Remember that calcium in your body is about 50% bound to albumin and about 45% in the free ionized state. Parathyroid hormone is responsible for maintaining your serum calcium and, by the way, magnesium via 2 primary mechanisms: renal reabsorption of calcium and bone resorption, which means pulling calcium out of bone back into the circulation. As an aside, when calcium and magnesium are brought into the bloodstream, phosphate is excreted. The hormone that works counter to parathyroid hormone is called calcitonin. Calcitonin inhibits parathyroid, and so therefore it wastes calcium and magnesium. It causes them to be excreted, and it saves phosphate. Remember that calcitonin is actually secreted from the thyroid gland, not from the parathyroid glands. And finally, vitamin D is a player here also. It exists in absorption of calcium from the GI tract in particular. What are the symptoms of hyperparathyroidism? Well, hyperparathyroidism is primarily a problem of hypercalcemia. Patients can be hyperparathyroid due to adenoma of the parathyroid gland or gland hyperplasia. There are certain multiple endocrine neoplastic syndromes that include hyperparathyroidism, and there are tumors that can lead to ectopic production of the parathyroid hormone. People can also have secondary hyperparathyroidism due to other hypocalcemic or hyperphosphatemic conditions. Patients who are hypercalcemic may have nephrolithiasis. They may complain of weakness. They frequently have polyuria, polydipsia, fatigue, depression. We do see hypertension, a short QT syndrome, which may even lead to heart block, as well as bradycardia, and finally peptic ulcer disease. And the famous mnemonic for this is stones, bones, groans, and moans, or psychiatric overtones. That's your hypercalcemia. The treatment for hypercalcemia is usually IV fluids and diuretics like Lasix. There are bisphosphonates that can be given in order to chelate some of the calcium. Calcitonin can be given to inhibit the parathyroid hormone. And in extreme cases, these patients may need dialysis. We should remember that pregnant patients do not do well with hyperparathyroidism. There's a high incidence of maternal and fetal mortality, and so we do surgically treat these patients even during pregnancy if they can't be medically managed. Here's just a quick diagram that reminds us of the location of the parathyroid glands. Two paired glands on each side of the trachea, intimately involved with the thyroid gland as well. So obviously when patients are having thyroid surgery, the parathyroids often are taken. And a lot of the considerations for thyroid surgery apply for parathyroid surgery as well, as far as nerve injury, airway injury, hematoma, and postoperative swelling. We also want to think about calcium and magnesium and phosphorus levels. Patients can become hypocalcemic in the postoperative period, and we'll discuss that again in just a little bit. One interesting point that the textbooks describe is a lot of surgeons will do an intraoperative parathyroid hormone assay, and some have described propofol as interfering with that assay. I think we're seeing that less and less nowadays, but that may still show up on an exam. So now we can talk about hypoparathyroidism, and the main problem here is going to be hypocalcemia. There are many causes of hypoparathyroidism, but often it's post-surgical, after the parathyroid glands have been removed. And post-thyroidectomy, the glands can be pulled out, or the disruption of blood supply to the glands may cause the glands to no longer secrete adequate hormone. About 30% of patients who have a thyroidectomy may experience some transient hypoparathyroidism, and so we need to be vigilant for that. And the symptoms usually don't occur right away, but anywhere between, well, I've seen as early as 6 hours, but a lot of the textbooks I looked at this time said 48 to 96 hours after surgery. I suppose it depends on how severe the injury to the parathyroid glands is. Remember, the half-life of parathyroid hormone is only 2 to 3 minutes. And I want to emphasize that a serum PTH drawn 6 hours after thyroidectomy is the single most reliable predictor of symptomatic hypocalcemia. So we don't want to look at calcium levels, and we don't want to wait until they describe signs and symptoms, but routinely we draw a serum parathyroid level in the postoperative period. Other causes of hypoparathyroidism might be neck trauma, certain malignancies, and severe hypomagnesemia. The signs and symptoms of hypocalcemia tend to be spastic and seizures. Patients can have tetanus, as described by the classic Chvostek and Trousseau signs. Patients may describe paresthesias. Again, some fatigue. Stridor can be an example of spasm of the vocal cords. And in the extreme, patients can develop congestive heart failure, hypotension, and long QT syndrome. Again, a lot of opposite symptoms from what we see with hypercalcemia. That's it for this video. We're going to stop here and pick up with the next video, continuing with endocrine in the perioperative period.